Hello and welcome to the ImpediMed webinar series hosted by ImpediMed. My name is Joanne Yao and I am the Senior Director of Marketing for ImpediMed. Today's webinar is titled How to Engage Patients and Promote Your Lymphedema Prevention Program. We have two very experienced panelists joining us today. Dr. David Edmonson, breast surgeon and director of the Lymphedema Program at Women's and Infants Hospital. Amber Carroll, physical therapist and certified lymphedema therapist at Cheyenne Regional Medical Center, and David Schull, managing partner at Russo Partners. So today's webinar will be a live panel discussion. We encourage all of you to participate by submitting questions via the Q&A icon on your screen at any time during the webinar. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we're not able to address live. We are also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your local ImpediMed representative. All of our webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel, and be sure to subscribe while you're there. Now I'd like to ask our panelists, Dr. Edmonson, Amber, and David, please join me and we will go ahead and start the discussion. Hi, Amber. Hi, Dr. Edmonson. Hi, David. Welcome.
Good morning to everybody.
Good morning, good afternoon. So, we're really excited to have this webinar at the start of Breast Cancer Awareness Month. This webinar today is all about awareness and all about communicating and educating about lymphedema prevention in the community. So before we get started, I'd love to hear a little bit about you and get an introduction. So Dr. Edmonson, would you kick us off? Tell us about your current role, practice, and focus areas.
Sure. I am a fellowship-trained breast surgeon at Women and Infants Hospital, which is affiliated with Brown University in Providence, Rhode Island. I wear a lot of hats there. I am the director of our fellowship program for breast cancer and breast disease. As mentioned before, I am the director of our lymphedema program, and I am the chairman of our cancer committee. As mentioned in the story that had played at the intro, I also did a course a couple years ago in preventative surgeries, and that sparked and set off our process of the lymphedema prevention program.
Thank you, Dr. Edmonson. We're really excited to have you on the webinar today.
Thank you.
Amber, may I ask you to introduce yourself?
Yeah. Hi, my name is Amber Carroll. I am a supervising lymphedema therapist at Cheyenne Regional Medical Center. We're in Cheyenne, Wyoming. We're about an hour and a half north of Denver. I have received my doctor of physical therapy from the University of Nebraska Medical Center, and I've been practicing for 15 years. And I've been a CLT and LANA certified therapist for about 8. I would say predominantly my caseload is lymphedema now. I see about 50-50 venous insufficiency, obesity-related lymphedema, and then the other half is cancer-related lymphedema. And we've taken on this new exciting adventure of doing a lymphedema prevention program. So hopefully I get to share some marketing tips and tricks that we've gotten started on.
Thank you, Amber. We're so happy to have you join us and really look forward to hearing more about your program and your marketing efforts and patient education efforts.
Yeah, thanks.
And David, if you wouldn't mind introducing yourself.
Well, hello to everyone, and what a great opportunity to speak with you today. What a pleasure during Breast Cancer Awareness Month and to work with the ImpediMed team on the kickoff of a campaign called Lymphedema Can't. I'm sure many of you have seen it. I come from the world of broadcast news, so the story that you saw with Dr. Edmonson back in my old days, that was the type of story that I would put together. So I am the president of Russo Partners. We are a boutique agency in New York City that works with emerging healthcare companies to tell stories of significance. We love to say that we're behind the stories that really make a difference to all of us, and it's focused exclusively on healthcare. My work with a team for ImpediMed, and I have a number of team members in New York City, who come from the world of science, medicine, and journalism is to find ways to help each of you build stories similar to what we saw with Dr. Edmonson. And why is that? There's nothing better than an authentic story of the benefits that one can derive from this type of program. So I was trained as a broadcast journalist at the University of Colorado. I worked in radio news in the great state of Indiana. I went to New York City and Miami to work in healthcare communications. And don't let the virtual background, convince you I'm in New York. I'm not. I'm in the home office in Miami, where the sun shines brightly every day. So it's good to be here, and we look forward to the discussion.
Thank you, David. We're really excited to have you. And of course, we appreciate all the work that you do with us and our team. So let's go ahead. You can see we have an excellent panel here. So let's jump in. Lymphedema. That's what we're here to talk about today. And as David mentioned, last week we launched our patient-focused campaign, Lymphedema Can't, really about educating patients about the risks of lymphedema and the opportunity for prevention. So we know that a lot of patients express concern. And even though the early detection and intervention, which can stop progression, which we're all familiar with, has been around now for quite a while, many patients don't know about it. They don't know that they need baseline. They don't know that they need routine testing so that their lymphedema can be detected early. So Dr. Edmonson, maybe you could kick off a little bit and just level set us. When you think about lymphedema prevention and what you're offering to patients, what does your program look like, and why is it important to you to have this available?
So it's a great question. So I think probably it helps to think of the evolution of where our program has gone. So as I mentioned in the story, I became the director of our lymphedema program about 11 years ago, and our lymphedema program has been in existence for far longer than that. We have an extremely busy practice between our breast cancer program as well as our GYN oncology program, and so our lymphedema therapists are extremely busy. And as you know, lymphedema therapists are hard to come by. Early on, as my role as the director, as mentioned in a lot of the stories you were playing up front, there really wasn't a whole lot that we knew that we could do to prevent it. We found that once it manifested swelling, that it required lifelong treatment. And we looked at it from a perspective early on from when LDEX came out in its initial form. And it was something that was very intriguing, but hard to put through the administration from a monetary and business sense. However, as the technology evolved and as the data set evolved, it translated into a lot of changes that we could use for the benefit of our patients and do what I consider to be bringing our program up to standard of care in terms of monitoring patients for lymphedema. It allowed us a throughput system to be able to easily and efficiently evaluate patients preoperative and postoperatively for lymphedema. The data that's out there in the prelim output from the PREVENT trial shows that it is more consistent and more dependable than standard tape measure evaluation of patients. I would argue from a time perspective, it is certainly much more efficient from a time perspective to get all the volume of patients that we need to put through the system from both preoperative as well as postoperative and follow-up perspectives. And we were able to create a business model that was one that we could use to make it work within the constraints that our administration set forth in terms of what we could do from a lymphedema perspective. So we use that in combination with a promotional marketing campaign as well as the preventative surgeries to really bring the whole aspect together in terms of all the different things that we could do to bring lymphedema prevention into the forefront of patients' minds, which, and prevention is worth a pound of cure. So it really seemed to be it hit the mark on what we needed to launch our lymphedema program into a different era.
Thank you. And you made a really interesting comment, which was to get the volume of patients through that you need to see. So when you say that, which patients are you testing? When are you testing them? Why is it such a high volume?
So our cancer center, just from a breast cancer perspective in and of itself, we have about 400 to 500 new breast cancer diagnoses within our office in a year. We have 5 different surgeons, and that's a very large volume. We had 4 lymphedema therapists. We're now down to 2. And so we needed a system and a mechanism by which we could evaluate these patients efficiently. So with that volume of patients there, we just did not have the personnel to be able to do those tape measurement evaluations in that manner to be able to appropriately monitor patients.
Okay.
Help me out with the rest of the question.
It's absolutely. And you're testing everybody, it sounds like, everyone who comes through
Oh,
your
sorry.
door
Yes,
gets
that was yes.
tested.
So we are testing
Yeah.
all patients with a new cancer diagnosis. We're even doing DCIS simply because, there are those patients that in which you find invasive disease and you have to do something with lymph nodes. And if you've already had some sort of surgical intervention, then you really don't have the ability to go back and get a true baseline. So we're testing all of those patients preoperatively, usually at the time that they come in to see the surgeon for their original discussion regarding their diagnosis and begin formulating plans for treatment. And then we'll capture them again at their post-op visit. And then we currently, in terms of what we have the capacity to do within our program, we're doing evaluations every 6 months.
Thank you, Dr. Edmonson. Yeah, that's very clear. And Amber, I saw you nodding your head quite a bit. Is the program you have in place similar, or is it different? How does it look at Cheyenne?
So I will say we're still pretty much in infancy. We went live in May, so we're having some growing pains. But I think what Dr. Edmondson's getting to is what our goal is. I'm actually the only CLT in Cheyenne. So relying heavily on our surgeon's office and our medical oncology group to do all those follow-ups for patients.
Okay, so you're sharing that responsibility. Now, when you have patients that come to you and they're getting tested, what does your education program look like, and what are you doing to encourage them to go ahead and get tested?
So this is right now a lot of education for me to empower the support staff at the doctor's offices, because I'm not in the same building. We're across town, so I need them to sell SOZO and the testing at that point. When I get to see them historically, it's actually before radiation, which is too late to do a lot of the really pre-procedure education. But as soon as I see anyone who's had breast cancer treatment, they get the lymphedema spiel. Even if I'm seeing them for shoulder pain or back pain, hey, did you know you're at risk? And there are things that you can do, and here's what to watch for. And now we have this really cool machine that we can use to catch it even earlier.
Excellent. And is there anything you can share with us that's helped facilitate that open communication with those referring providers that you work with?
Right now, I really think the providers are on board. Everyone's seen the research. We know that it's a great thing that works. Right now, it's kind of that trickle down, to the MA level. And quite honestly, we're having probably the biggest hiccup with the cost piece and the insurance, which is an awkward conversation for some staff to have with patients, especially when it's like, hey, you were just diagnosed with cancer and here's something else. So that's what we're working through right now, honestly.
So Dr. Edmondson, when your patients come in to see you, how are you educating them about lymphedema and having those conversations?
Yeah, so given that we're at an academic center, we have fellows, residents, medical students coming in on a day-to-day basis. I would say education is a part of our mantra in terms of what we do. We not only try to educate the learners that are with us, but we also feel very strong about educating patients and reviewing with them the potential risks and complications that go along with anything that we do from a treatment perspective. And I think lymphedema certainly has come to the forefront of those discussions. And so we use a series of images as well as just verbal education to explain to them what lymphedema is and how it can be a problem going forward, and that there are preventative strategies that have been shown scientifically to help prevent it and minimize the risk for that. And I think it's something that is very easy to translate to all of my colleagues, because we all feel very strongly about teaching and education. And so it just kind of comes naturally to all of us, and that all gets transmitted on to the patients. I think the current mantra, especially in breast cancer treatment and management, is giving the patient the information that they need and allow them to make educated decisions. So if you're not educating them with respect to all aspects of their treatment and their care, then you're doing them a disservice. And so we feel very strongly about educating patients. And so that piece of it just comes very naturally.
Yeah, that's wonderful. Thank you. And we're going to talk, we have some of the market examples from your practice, Amber. We're going to get into some of those very specific patient education materials. The other aspect you brought up, of course, is the financial aspect in the case that patients might have to pay for their own test. And I just want to let the audience know that our next webinar in November is all about reimbursement. So we're going to talk about billing best practices, strategies, having those conversations. So we're going to cover that at length in November. We can touch on it here as well, but I think we also just want to make sure that we get really comfortable talking about the benefits of talking about lymphedema with the patients, and then also talking about prevention. So David, I mean, you're a communications professional. What are some of the best practices you've learned as a broadcaster?
Well, I used the term earlier, which is authenticity. And when you think about that, the patient stories are very powerful. I have a recent example that still sticks with me after about a week, and that is everyone knows that what dominates media. So let me step back a minute and say, we work in communications through multiple channels. We break it down into what we'll call earned media, which means traditional media, broadcast news. You saw the television news segments that aired on the Loop earlier, newspaper, magazine, online. So those are traditional news sources that report on healthcare developments, innovation, and treatments. Healthcasts on the news are very popular. These days, you don't find as many dedicated health producers because of budget cutbacks, but there are still reporters, as you saw the one with whom David worked, who focuses a significant amount of time on doing reporting on medical breakthroughs that matter to the viewer. So earned media is one channel per se that we can use, and it's very effective. We look at owned media, which owned would be channels that a hospital owns, a medical practice, ImpediMed, that's controlled content that goes through regulatory approval. It appears on social channels. So we look at these, and then there's paid, and we know paid involves advertising and search and more. But I'm going to spend most of my time talking about my background in earned media, because those are some of the best examples that are actually right there at our fingertips for use if we have the ingredients for success. Authenticity is absolutely critical. To be able to have a patient's voice to a story, discuss the need, the fear, and then to be able to communicate how this program has made a difference, it enables us to demonstrate the technology in action. As I said, just about a week ago, I wrote to a USA Today reporter named Karen Weintraub, and I did it because as Breast Cancer Awareness Month kicked off, USA Today ran a big feature article about innovations with breast cancer treatment. Now, I've worked with Karen over the years, and I wrote to her and I said, Karen, great article. Good to see it's not something else about a COVID vaccine or treatment. Very timely. Have you thought about lymphedema? And have you thought about doing a story that would show the innovation in what most breast cancer patients say is their greatest fear when they're diagnosed with the disease? Many journalists don't have time to respond immediately, but she did. And she said, as you probably noticed, David, this is one of the first bylines that I have that is not about a COVID vaccine or a COVID treatment and development. And I'm happy about that. And I know that lymphedema is an important story. And if I can do something to help tell it, I will. So the fact of the matter is, as we tell this story, the more that we talk about it, the more we learn of authentic examples, patients, family members. I see it and I hear it. I've had journalists tell me, one of the stories that is on the loop was taped in Northeast Pennsylvania in the city of Lewisburg. The news anchor, Mark, whom you saw conduct the interview, said to me and my teammate, I'm so happy we did this story because we have a team member here in our newsroom who struggles daily wearing a compression garment. So what I'm seeing and hearing is that this story touches all of us. And the fact that we have technology and innovation that can make a significant change and fit easily into a program, it fits nicely. So leverage the communications channels that are there. I think you'll find that people want to talk about this and that there are opportunities to work through earned media and more you can do with the other marketing materials you have. But it's a good story. It's a good story. And I'm sure Dr. Edmonson, you'll agree with that, having done much of the media work in Providence for many years.
Yes, agreed. That is actually, so as you mentioned, the reporter that we work with does almost exclusively medical media. And she knows very well, every time we get involved with Barbara, she's like, you need to get a patient that you can use within the story to tell their version of the story. They know that that helps to tell the story. And so as I think through when we put these marketing or media stories together, that I need to think through who is that patient that would be a good storyteller, who has a good story to tell and would be good on camera. And so that's something that's now in the back of my mind as we start thinking about various stories we want to tell with respect to new medical technology that we're using here at our institution.
Yeah, let me add one point to that. There will be phases as you roll out your lymphedema prevention program where there are different communications vehicles and channels that are appropriate. It might be that in the beginning, just as Amber did with her team in Cheyenne, you issued a news release, Amber, and the news release received local media pickup. It was used to distinguish and differentiate the work that you were doing to highlight the fact that you have a lymphedema prevention program, and it's good for the local audience. So you started with that, and that was before you got to the point where you have a patient because you're just rolling it out. You stated clearly it's in the infancy. But as these programs progress, you'll be amazed at these stories that we hear. And I think everybody wants to get involved with it. When we hear the patients tell their story about the fact that we had one that Joanna and I just experienced a couple of weeks ago where the doctor, and this was a doctor in Houston, said to us just before the patient went under anesthesia, the last words spoken were, I hope I don't get lymphedema. So the point is we're onto something here with these authentic stories. And if you can leverage them and work them into a communications mix, you can help to do what we say. We're here to educate, not to promote. It's not about promotion and we're not hyping anything. We just believe that it's in everyone's best interest to educate about lymphedema, to call attention to the fact that there can be something different today, that you can prevent lymphedema from becoming a chronic condition if you begin with some testing.
Absolutely, David. And that's really well said. Thank you. And it gets into, we got a very relevant question related to that. So let me just share with you guys the question and then let's get into some of those materials that you referenced, David, that Amber did use, right? Early stages of her program. And like you said, she hasn't been testing enough to have a patient story yet. So let's look at that. But we got a great question here from a woman who's running a research study using LDEX for early intervention, the model that we're talking about. She's finding it's difficult to capture her patients preoperatively. So getting that baseline test, patients are overwhelmed when she's saying patients are overwhelmed when they're diagnosed with cancer. So what are some of the tips to help streamline this? So maybe Amber, Lisa, if you wouldn't mind sharing the slide we have about Cheyenne's work on some of their communication tools. And then Amber, if you wouldn't mind walking us through the approach that you took to put these together and start rallying support in your system and with patients for what you're doing?
Yeah. So the first one was our press release that went out in the local news, 2 new local newspapers. And that was really ImpediMed made it super easy. I mean, you guys have prepared material. My marketing team really ran with it. Cheyenne's a smaller community, so they have a great relationship with media outlets in town. So that got me invited onto a morning AM radio station. So I got to speak with them about, what is lymphedema and what's this cool new technology that we have now. We updated our website so that there was a reference, when patients had questions, they could go on and read more about it. On the left side is this is the handout that we provide to patients. So this will be going out, at their breast surgeon's office after that first visit, at their medical oncologist. Here you can go home, read more about it. And we decided to put our logo on it and print it ourselves. But we have this available for patients. I think just trying to streamline your process at that provider office, make it easy for the patient, make it, put the machine right next to the scale, have it just in your process for someone to help with. The fewer steps the patient has to take, the less work it becomes. It just is what it is, I think is kind of especially the goal that I have in mind for our program.
Excellent. And these are wonderful examples. We have a couple of questions coming in that relate to this kind of referral chain. And so, Amber, when you receive someone for testing, what diagnosis typically do they have when you get a patient that needs to be tested using LDEX?
Yeah, and so I'm the lymphedema PT, but my hope is that I probably don't even touch these patients yet. So these are new patients, new diagnosis of breast cancer right now is what we're starting with, and everything's going to get started at the doctor's office. So this is someone who's coming in for a consult for a lumpectomy or a mastectomy. These are the patients that we're trying to capture data on first, and then the follow-ups will continue after their treatment continues. Does that answer the question?
Yeah, absolutely. And thank you, Amber. I'm going to actually ask Dr. Edmonson the same question. You work in a teaching hospital, so slightly different environment from where Amber's practice. In your hospital, who does LDEX, and at what point do you trigger that? Do you refer them to OT-PT for lymphedema therapy?
Yep. So what we have done is incorporated into the process of a new cancer patient coming into the practice. And so it is just a part of the process. And part of that is making sure our MAs are aware of the diagnosis that these patients are coming in with. When they know that it's a new cancer patient, they know that we need to do bioimpedance measurement on them. And we've empowered the MAs to say, there are checklists on the paper checkout form to make sure that it gets done. But at the same time, there's that communication with the MAs, the empowerment of the MAs to get them involved in the process. And hopefully, as they see this technology work and potentially see this technology prevent lymphedema and see those success stories and try and, put forth the idea that they helped to prevent this patient from getting lymphedema, hopefully that'll have kind of a snowball effect and have them take ownership of it and want to do it more and help us to continue to monitor these patients as they come back for their 6-month follow-up visits and look for it and ask about it.
Now it's interesting because you're saying that the MAs are the strength of your program, and Amber is saying that getting her MA team on board is the challenge she's facing. What advice might you give Amber to help her take away from this webinar to go educate her MA team?
So again, I think education is key. Getting the MAs educated on why we're doing this test. What are the potential benefits of this test and what we can prevent? Most of our MAs have been with our practice long enough that they've seen many, many patients with lymphedema. And so they know how troubled these patients are by the lymphedema and how their daily lives are impacted by it. And so if by educating them that this technology can potentially help to prevent it, they can be involved in that process. And so I think, in many cases, education is the key. And if you educate them and teach them as to why we're doing these things, I think they're more likely to take ownership of it and take over the process themselves.
I like that idea. Yeah.
Yeah, thanks. And I think we have, talking about education tools, we went through the materials that you had put together, Amber. Again, we're going to go through them also. ImpediMed has a lot of resources to help support these efforts. David, any other thoughts on, it's interesting because we set out this webinar to talk about patient education, and now we've identified we don't just need to educate patients, we need to educate the teams in our own practices, right, to participate in this testing model. So any thoughts from you on best practices you might have seen from other companies that our users could benefit from?
Well, let's stay on the healthcare professional audience for a minute, just because of the discussion. From my experience, it's data-driven and supported. And if we can use the data at hand to our advantage, then we're in a strong position. And this is a case where the data can stand on its own and speak for itself. Think about what we have through publications, and we expect even more publications to demonstrate the benefit of the use of and knowing the LDEX score. If the majority of patients can benefit by a healthcare professional knowing the LDEX score and using that from baseline to then determine whether there's a trigger to treat, so our test trigger treat protocol, it almost gets to the point of how could you not utilize this, especially when you hear these stories of patients who struggle immensely. Interestingly enough, when you had, Amber, you had your materials up from ImpediMed, there's the beautiful document with a smiling Dr. Cherie Prentice, who's hosting a Facebook Live event that I believe everybody knows takes place. And if you want to have Cherie lighten up the room or bring energy, it's there. She's a lymphedema survivor, and I've interviewed her and worked with her on some television interviews. When you hear Cherie talk about, as a physician, the fact that she was not able to practice because lymphedema got in the way, you knew then that from the healthcare professional standpoint, she said to me, get that data out, continue to communicate, and cross over and go into that patient communication zone because we need to educate. So it's almost as if we have something so simple, but yet just isn't known widely enough that we can make a difference. And if that's the challenge, that's an easy one to overcome. It just takes commitment and time. So in reaching both a consumer audience and then a healthcare professional, the tools are out there. The information is readily available. The data are good. This is a strong data set. And I'm sure Dr. Edmonson, that's what you hear too, is we look at the data. If the data dictate that this can make a difference, we're gonna try it.
Yep. And that was a large part of the compelling argument that we made with the administration. Here's the data to show that it makes a difference. And I think, finding whatever venue you can to educate not only colleagues, but also the community is great. Along those lines, I'm doing a educational piece for our fellows tomorrow on lymphedema and lymphedema prevention. I'm doing a grand rounds for our institution later on in this month. And there's another community-based event coming on later in this month as well. And so I think there's what David said is absolutely correct. Realistically though, the conversation has changed in the last 5 years. The data that we were waiting for is now there. And so we can now use that data and start to communicate and start to get the word out. I think a lot of people shied away from talking from lymphedema prior to having this data available. And because, as surgeons, we knew we caused it. And we knew that we had left these patients with severe debilitating problems, and we had nothing we could do about it. Now that conversation has changed, and so I think you're right. Getting the word out, educating, and doing it in a lot of different formats and through a lot of different audiences to get that word out.
Thank you, Dr. Edmondson. And we just those are great points. And so here's a great question from the audience. And I think this is a very honest question. So this audience member writes, I'm an OT-CLT, and I've been trying for the past 2 years to educate our providers and surgeons in our breast center on early intervention prevention and the importance of pre-op evaluation. I've shown the research, provided them with patient stories, and I was told the surgeons don't want to have follow-up with the patient after surgery or sign off on my notes, and that's why they won't refer to me. Any ideas on how to convince them?
Stubborn bunch. Well, I mean, do you go through a different avenue? Do you attack it through if the surgeon? So every practice has a different protocol for how they follow their patients. Sometimes the surgeons are not always the ones that are prospectively following their patients as they go forward. There are practices where the majority of that is followed by the medical oncologist, the radiation oncologist, and or their primary. And so if the surgeons aren't receptive to it, go after the other providers. I think educating the primary care providers is absolutely key. That's the whole point of our grand rounds, to capture those outside of our catchment within our own practice, to educate. And sometimes my thought would be go after the other providers that are involved in that patient's care. If the surgeons aren't able or willing to do it, find somebody who will.
It's a great piece of advice. Thank you. Now let's talk a little bit about the media, right? That's one of the key topics here, is working with the media. Most clinicians don't necessarily have experience there. All three of you in this panel do have experience. So Dr. Edmondson, you've done TV. Amber, you've done radio. David, you're a former broadcast journalist and media professional. So Dr. Edmondson, let's talk a little bit about your TV news segment. So first off, you're in a university setting where they are concerned about brand promotion. So could you talk a little bit about how you've overcome that challenge in case some of our audience runs into that challenge? And then second, just a little bit about your experience being on camera, working with reporters. What's that like?
So I was thrown to the wolves with that one many years ago. So my mentor, who was my boss, who was also my fellowship director 18 years ago, thought that what would fit well with my personality is looking at the new technologies, testing them out, see if they work, look at them from a scientific perspective and go with it. And so that's where it all started. We were doing some new things with technology within our program. Similar to Amber's experience, they put out a news blurb, and it was captured by one of the local news segments, same reporter. And the media department came to me and said, would you be willing to talk to the media about it? And I wasn't one who had been in front of the camera ever before. I had not had a lot of experience with other colleagues that had, but the advice I had been given from one of the founders of our program is always go into everything prepared. And so, I thought as I knew this story was coming up, I watched a lot of segments. I tried to pick apart what made one segment interesting and one not. And I think there's a lot of truth to what Dave said about the honesty and the capturing that true nature of a person and telling that story in an empathetic way. And so as I thought about that is how is this impacting patients? How can this educate patients? How can it drive patients in to want to seek out this technology? And so a lot of it was, thought process all by myself, saying, what is the story I want to tell? What is the message I want to get out there? Always having education as a baseline.
What's
And
the impact you've had? I mean, have you had any feedback?
oh yeah, so patients talk to me about it all the time. Oh, I saw you on TV. Oh, I'm seeing it. Oh, sometimes they don't realize that when they're coming in to see me, I was the guy they saw on TV several years ago. Oh, I know who you are. I saw you on TV. And so I hear about it quite frequently from between, I think I've done 6 or 7 stories at this point in time. And so my face has been out there a number of times. And so that recognition is coming out. And I think Barbara, who is a reporter, does a very good job. In terms of the branding piece, one of the pieces of advice I did get from my colleagues was you cannot use brand names. And so we use general terms, bioimpedance spectroscopy. Don't use the term SOZO, don't use the term ImpediMed. And you can keep yourself out of trouble and out of the scrutiny of the hospital by avoiding those specific terms, but still tell the story, explain what those technologies are, what they mean, and how they impact patients.
Thank you, Dr. Edmondson. Really wonderful comments, and so exciting to hear that people actually see the segments and then come see you and recognize it. So that's evidence that the message is getting out there. Now, Amber, you did radio. Can you tell us a little bit about your experience being on the radio?
Yeah. So our hospital CEO regularly goes on to a morning radio show and talks about cool new things that are happening at the facility and new technologies. And so I got invited to speak with him. I was terrified. I had never done anything like this before. And so I went in with paper notes, and it really ended up just becoming a conversation. Radio is you're talking to a guy in a room, and he asked about what lymphedema was, and I got to explain the nuts and bolts of it and the excitement that we have for this new technology. And it really just it was just a conversation that other people listened to, I guess. I did not hear a lot of feedback from that, but I don't know how many people listen to AM radio in Cheyenne on a Friday morning.
It sounds like it was a fun experience that ended up. Go ahead, Dr. Edmondson.
I was going to say, if I can add to that, I was terrified as well. Preparation will take you a certain distance, but not the whole way. But, I had this idea that they were going to film straight through, cut to cut, and that's what you did. And in between was it. The reality is, kind of like Amber said, it was a conversation. And they picked and chose what they want and mixed it up and matched it and made it all look really nice. And so there were brain farts, there were weird, awkward pauses, but they had, the nice part is they film it ahead of time and they have the ability to cut it out and splice it in a nice way that makes you look good.
So, and that's a great point, right? At the end of the day, David, the goal of the reporters is to have it look good, right? So
just tell a story. Tell a story. Well, here's the story. Yeah, and what's interesting too is you have Dr. Edmondson, who was on television. You have Amber Carroll, who was on radio in Cheyenne, Wyoming. So you also have to ask yourselves as program leaders, and when you integrate with marketing professionals in your hospital, at your practice, where do most of your audience members go to get information? People would think that with traditional media, it's the local newspaper. Well, you would be wrong, or they would be wrong. Television news is still one of the most popular vehicles. And as a matter of fact, when you look at television news in local markets during pandemic years, you see stations that have increased their news programming. And you can have newscasts here in Miami on Channel 10. We have it at 4 o'clock, 5 o'clock, 6 o'clock. They cut for 30 minutes to the ABC nightly news, and they go back at 7 o'clock. Why is that? It's actually less expensive for the stations to produce than for the stations to pay for syndicated programs such as Wheel of Fortune or Jeopardy. Also, during the pandemic, there's been a land rush to get more information on health topics and stories. So what's interesting is we're all connected on Zoom. We've done many interviews like this. We've done interviews on Zoom where nobody enters your facility, And we then provide what we call B-roll, which is just video footage that shows a patient, a measurement being taken on a SOZO device. And that alone is a new way of approaching it. The key is, I use the term authenticity, get patients involved, human interest. The human interest component here is big. I can't stress enough, I've been working in this field for more than 30 years. I started in radio in a small town. I had to push buttons, rip wire copy off, and make stories. I have a teammate who works with us at Russo and also works on ImpediMed. He's a former ABC network news producer. And I used to pitch him stories 25 years ago when he was the local producer in Miami. What Scott will always tell us on my team, nothing can replace the benefit and the value of a good human interest story. That's what people want to see and hear at home. So think about the progression. Amber has beautiful materials that she's used to help the Cheyenne team communicate locally that you have that program. That's step number one. Then as you advance it and you test patients and you have patients come back for those follow-up visits, you can do more of what Dr. Edmonson has done. And you heard Dr. Edmonson state, people watch, they contact. It's about creating an operating environment of informed publics, meaning that your audiences, whether it's the patient community or even those on the healthcare professional side, as we've learned a little today of where you need to work, it all helps. It contributes to a positive operating environment. So just be a storyteller. And those stories are there for the taking and for using.
Thank you, David. Those are great comments. Now, what I'd love to do in our last 10 minutes is first, Amber, you mentioned that you did get use some of ImpediMed's materials to help you get started. Lisa, if you wouldn't mind putting that slide up, I just want to show the audience quickly what we have available. If you're interested in enhancing your patient education, your referral marketing, or your community outreach. If you visit ImpediMed.com, on our newsroom, you can see all sorts of examples of news. We also have an online media kit that has templates, brochures, and fact sheets, examples, for media outreach, referring physician outreach. I mean, we have a lot to offer. So if you're interested in engaging with us, please contact us. Please contact your local representative. Go to our newsroom. You can submit a form there. Or just send us a Q&A right now, and we will get in touch with you to help you take advantage of these tools. Thanks, Lisa. I just wanted to share that, and you can take this slide down. I also wanted to go back to some questions that we've been getting that relate to some of the topics we hit on earlier in our webinar. So thank you, audience, for the questions. If you have more, please go ahead and send them through. We have a therapist who has, SOZO in her clinic, in her therapy clinic, but it's not in the doctor's office. And she wants to get patients for baseline testing. At what point, or Dr. Edmonson or Amber, do either of you have experience with, getting patients before treatment begins into the therapy department? What's your experience there?
So again, our strategy and the process that we put together was to put the machine initially in the clinic setting, which is literally one floor above where the lymphedema therapists are at the moment. We felt that we would be better able to capture those patients and follow them in the means that we desired to do, and as we laid out in our protocol. The second piece of that has been a little bit more of a struggle for reasons that I cannot explain, is to get we have another device, but it's not in use, and get that into the lymphedema setting as well. But for as far as optimizing bang for your buck, where you're going to have the majority of the patients seen and evaluated, if you look at it from a statistical standpoint, that's going to be in the clinician's office. That's where these patients are coming and going. That's where you want to capture them preoperative. That's where you want to capture them postoperative, and as they come back for their follow-up visits, as opposed to those coming in with new bump ups in their score or signs, symptoms of lymphedema, and having that specific referral down in the lymphedema office in and of itself in our particular setting was less of an impact, and I think that might have something to do with why they've been slow to roll out that second machine. In the academic setting, there's always some sort of administrative bureaucracy and hurdle to jump through, and I don't know, I think it's a power thing where they like to keep things from you, just maintain some sort of control.
I guess I'll hit on that a little bit. So I've been, since we don't have true baseline measurements going up and running yet, I've been testing my pre-radiation patients for a post-treatment baseline. And so I've caught some early lymphedema from just that. So I mean, think outside the box maybe until you get the process running for a true baseline. But so anyone that comes in, you know, I'm trying to catch those and get those measurements right now.
Yeah, I think that's a wonderful point, which is to the audience member who asked that question. I mean, even if you can start testing after treatment, you still want to capture those patients. And then we did run a webinar in January about the prehabilitation model, right? So that's getting patients to therapy before they start their treatment. That is taking place in a number of centers, including with some of our customers. So if you're interested in learning more about prehab, the process for getting patients to you in therapy before they start treatment, please reference that, reach out to your ImpediMed representative. We definitely have customers who do that. We've been more than happy to share with you some of the ways that they get the patients to them, including, you know, using some of the referral materials in our media kit. One other question is about data. So Dr. Edmonson, you mentioned the data's there, and one of the questions we got is, in addition to the PREVENT interim results, are there any other data points that make the link between early detection and treatment and better outcomes?
So I'd say there's some studies that were done early on prior to the PREVENT trial that started to give some glimmer into the idea that this technology can be helpful and beneficial from that point, especially coming out from the early iterations of the LDUX when it was 2 electrodes attached to the little gray box. I think the big difference that comes out of the PREVENT trial is that it's a randomized controlled clinical trial. And so there was rollout of the initial interim results that came out in 2019, as you mentioned, that I think really got the conversation started. I think that's where academicians like myself really felt that the data was there and compelling. Because there was real good data. It was much larger numbers, and we are all anxiously awaiting the final results that are supposed to drop sometime soon. I'm waiting to throw it on our journal club list for our fellows so that they can go and take that throughout the country when they leave.
That's excellent. And for anyone who wants more evidence there, you can go to ImpediMed.com, our clinical evidence page. We have all the prevention studies there. As Dr. Edmondson mentioned, in addition to PREVENT, there's 6 other studies that are single center studies looking at this model of care in a variety of centers, everything from university to private practice. So definitely multiple different approaches to implement the same methodology. Also last year, there was a meta-analysis on 50 studies and over 50,000 patients comparing lymphedema detection methods, looking at none, looking at LDEX, and looking at tape measure, definitely showing that monitoring with LDEX and intervention reduces the rate of chronic lymphedema by 81% compared to tape measure monitoring alone. So really strong evidence. All of it's on our website, and all of it can be accessed if you contact us as well. So we'd be more than happy to help you with that. So I think that's a lot of the questions. Let's see. So we're just getting a lot of, I'm just looking at the Q&A, we're getting a lot of thank yous. The thumbs up to the 3 of you. I think just kind of as we close out the webinar, you know, one other topic that we've touched on, but we didn't really go into in depth yet, is working with your marketing colleagues. So I know, Dr. Edmondson, you have a very strong relationship with the marketing team at your hospital. Amber, you spoke early on about the work you did with marketing. So Amber, would you talk a little bit about how you integrated your marketing colleagues into this and how you got them on board to help you out?
I think my clinical implementation team with ImpediMed really did most of the work with that. I just gave them the name and the email and set up that first meeting, and they marketing has their own language, just like medicine does. And so they came up with a plan, and we decided what we wanted to do and roll out first. And so now we're kind of getting close to that time where we're ready to re-meet. And, I have patient stories now, and we can kind of think about what that next step is once we get all the nuts and bolts process going. So it's, me as not a marketing person, I just let the professionals do it. And
that's great.
They worked great. Yeah.
Got the introduction, got them on board. And when do you think, this question for any of the three of you, what's the right time to engage them? When do you want to get them involved in the process?
So I can at least give you our experience. Was we wanted to put a process together that we thought would be workable and functional within our office. And so we went through a lot of the details. There were several meetings that took place between myself, the other surgeons, and the business administrative side from our office. And after we had those pieces put in place, we were ready to roll it out. That's when we got marketing involved and said, we want people to know about it. In part because our direct competitor is literally across the street. And we are always trying to set ourselves aside from the other groups. So when we do something, we want to make sure that it is good, it's polished and ready to roll. So that was our strategy, and that's how we decided to get them involved.
Thank you. And Amber, you were going to make a comment as well.
Oh, I think we reached out to them right at Go Live. So
which is great, and kind of speaks to what you were saying, David.
Yeah, it's exactly at the go live. And so the planning work should take place in advance, because we know that some have questions. How do I get started before I have patients? Amber has a great case study of look at Cheyenne's accomplishments by issuing a news release, by communicating locally. There was pickup, interest, radio segment, all of that before the first tests were performed. So you have the ability to do this, as I said, in stages or phases. Plan early, get the marketing team involved. You can bet that you're going to have something very unique as you roll this program out, which is good for you in general to communicate to the patients in your area of what you're offering.
Thank you. Well, listen, we are at the top of the hour. So this has been a really fun discussion. I think we covered a lot of ground here and dug deep on LPP, patient education, referral discussions, and can't thank you all enough, Dr. Edmondson, Amber, David, for your participation, sharing your experience and insights with our audience. So thank you very much. And if anyone has any questions, comments, or needs help, you can find us at ImpediMed.com, and we'll look forward to hearing from you.
Great. Thanks for having me.
Thanks again, and everybody have a great day. Thank you to ImpediMed.